So a few days back, I made a very short video on what is the difference between type 1 and type 2 respiratory failure. So some of my students asked the question that how do we treat type 1 and type 2 respiratory failure when there is a difference in the underlying pathologies, type 1 being actually a problem with oxygenation and type 2 problem with retaining carbon dioxide or ventilation. So let me simplify the treatment of type 1 and type 2 respiratory failure. Now, type 1 respiratory failure is more common than type 2 respiratory failure. In your clinical practice, especially in clinical pediatrics, you will see that type 1, you will come across type 1 failures more often as compared to type 2 failures. Now, type 1 failure is, it's the actually low oxygen levels in your blood. And why low oxygen? Because there's some pathology in the lungs at the level of the alveoli or at the level of the bronchioles. So what happens, either because of the inflammation, infection, mucus plugging, whatever, the air which the child is taking in, the oxygen component is not fully able to cross into the blood. So what would happen is that the blood oxygen levels would be low. Now, because there is underlying pathology is inflammation, infection, so on one hand you have to treat the underlying cause. So for example, if there's mucus production, you have to give something to clear up the mucus. If there is infection, you have to give some antibiotics to clear up the infection, or if there is an inflammation, you might have to use certain types of anti-inflammatory medications like steroids to calm down the inflammation. But for the sole purpose of improving the oxygenation or improving the oxygen levels in the blood, the treatment is very simple. You have to give oxygen. Now, the most common way of giving oxygen is giving oxygen through a non-rebreathable mask. This is usually used in most of the acute settings, emergency presentations. So if a child is coming with low oxygen levels, low saturation levels, the blood oxygen levels are low, so what you're going to do is, the first thing is, obviously you will treat the underlying pathology at the same time, but to improve the oxygen levels at that point in time, you're going to give oxygen to the child. So the first thing that you can grab is a non-rebreathable mask and maybe start on high flow, 15 liters per minute oxygen. So that's going to improve the oxygen levels like within seconds to minutes. Sometimes after initial improvement, you might go down to some lower levels of oxygen. So for example, you might have to use, let's say, 2 to 4 liters, in which particular scenario probably you would be using nasal cannulas. Sometimes you have to even use a higher level of oxygen, like for example in certain cases of severe bronchiolitis, where you would be using humidified oxygen via vapor thumb machine. So it depends on the underlying condition, but the most simple solution to improve oxygen or oxygen problem is to give them oxygen. So you give them oxygen depending on their oxygen needs, and that would improve the blood oxygen levels within seconds to minutes, and at the same time you then treat the underlying condition as well. Now, if the condition is very severe, let's say your oxygen, like this simple method of giving oxygen through a mask or through cannulas or any other method is not working, then you might go for some more advanced methods, like for example non-invasive ventilation. In non-invasive ventilation or positive pressure in ventilation, you are basically pushing the air with some pressure. So you will set a sort of a PEEP, positive and expiratory pressure, and with that you will be pushing oxygen into the lungs of the child. So what that does is basically that apart from giving oxygen, which a mask also gives, this positive pressure actually recruits the alveoli. So as the pressure goes in, those collapsed alveoli, they open up. So they would pop open, and that would improve the diffusion of oxygen across the alveolar membrane, improving the oxygen levels. So non-invasive ventilation can be given, and obviously if worse comes to worse, then mechanical ventilation is the ultimate solution. But in most of the cases, like for majority of the cases in acute setting, probably you would be using your oxygen devices like non-rebreathable masks, like nasal cannula, or like vapor thumb, or maybe some form of non-invasive ventilation like a CPAP, or giving some form of, or any other form of positive pressure ventilation, which actually helps you in recruiting the collapsed alveoli of that child. So this in simple is the treatment of type 1 respiratory failure because of any underlying pathology. Now coming down to the type 2 respiratory failure, in which the primarily pathology is elevated levels of carbon dioxide. It is usually associated with either normal oxygen levels, or sometimes the oxygen levels might be low, but the basic pathology are high levels of carbon dioxide. Now here the problem is slightly different. Why would carbon dioxide be retained? Carbon dioxide is usually retained when, number one, you've got the same pathologies that are causing type 1 respiratory failure, but at the same time the musculature that is automatically working to breathe in and breathe out, that is getting exhausted. Like in most of the, let's say, a child who's got pneumonia or who's got acute asthma, when they come, the respiratory rate is high. Because the respiratory rate is high, the work of breathing might also go a bit more higher, and the child still tries to take a lot of air in, and while there might be problem with oxygenation, the carbon dioxide levels are still normal or maybe on the lower side. Why? Because the respiratory rate is higher and the child is blowing off carbon dioxide. But let's say in the same illness, let's say acute severe asthma, finally the child becomes exhausted, it goes into life-threatening asthma, the respiratory rate goes down. What would happen? Now this child would start retaining carbon dioxide. The same occurs if a child had some form of poisoning in which there is respiratory depression, like opioid poisoning. Some kids, accidentally can take their parents' opioid medications, and they can suffer from opioid poisoning. Or it can also happen in certain types of neuromuscular conditions, Guillain-Barré syndrome being one, like ascending polyneuropathy, in which the paralysis sort of ascends and can involve the respiratory muscles. So if the respiratory muscles are involved, those respiratory muscles will not be contracting properly, so the respiratory rate and the respiratory effort would be affected. So when that is affected, whether oxygen levels are affected or not, the carbon dioxide levels are definitely affected, and the carbon dioxide levels goes up. Now, how would you treat this condition? For this condition, you have to blow off carbon dioxide. Now, how would you blow off carbon dioxide? Remember, blowing off carbon dioxide in medical terminology is known as, we call it ventilation. Now, how do you improve ventilation, or how do you improve blowing off carbon dioxide? Two ways. Your ventilation basically is your tidal volume times respiratory rate. So there are two variables here. Tidal volume is simply the amount of air that goes in with every breath, and respiratory rate, very simple, the amount of respirations that a child has got per minute. Now you have to either improve the tidal volume or you have to improve the respiratory rate. Now the easiest way is to improve the tidal volume. Now how would you improve the tidal volume? A child is tired and less amount is going, so you would give him some form of non-invasive ventilation. So either would you use CPAP or you might use BiPAP. BiPAP is a form of CPAP in which the two different levels of pressures are used, a separate pressure for inspiration and a separate pressure for expiration, so that the child has got it's easy for him to breathe in and it's easy for him to breathe out as well, because we are more interested in breathing out the carbon dioxide. So you've got different pressure levels. So non-invasive ventilation in the form of CPAP or BiPAP. Now what this does, this non-invasive ventilation, you can set the tidal volume. So it would take a specific amount of air that you set on the machine, and that is what we call as tidal volume. So you would be actually, when the child takes that weak respiratory effort, so on top of it, that machine is gonna send that air with some pressure into his lungs. So when that increased amount of air goes in, that increased amount of air would also come out, and that would bring the carbon dioxide with it out. So I'll be blowing off carbon dioxide. So one way is increasing the tidal volume by either CPAP or BiPAP. So that increased amount of tidal volume would bring back the increased amount of carbon dioxide that you would be blowing off. Number two, you can increase the respiratory rate. Now a child who is breathing in, breathing out, let's say who is otherwise awake and has got a spontaneous respiratory rate, let's say if it falls down to very low levels, then you can increase it with different methods. For example, in an emergency setting, you can start bag and mask ventilation. So bag and mask ventilation, when you press, you're not only you're sort of setting the rough tidal volume, but you're also the number of times you would be pressing it, you're also setting the respiratory rate. So the more you press that thing, the more would be the respiratory rate, and that increased respiratory rate would blow off carbon dioxide. So the more you press that bag, okay, the more you would be pushing the air inside, and you would also be doing it at a, let's say, at a faster rate that the respiratory rate that you have set. So what would that do? That would blow off the carbon dioxide. And if worse comes to worse, then you can always sedate the child and do intubate the child and do mechanical ventilation. So in mechanical ventilation, what you do, you are actually taking over the physiology of that child. So you are basically making that machine do the work of the lungs. So you set the target oxygenation levels, you set the inspiratory time, you set the expiratory time, you set the tidal volume, you set the target respiratory rate, and then you give it through the machine, and that what it does, it blows off carbon dioxide and brings the increased level of carbon dioxide back to normal. So this is how type 2 respiratory failure is treated, that we either treat it in acute setting by a bag and mask ventilation. Again, the philosophy is that we have to increase the tidal volume, or we have to increase the respiratory rate, or we might have to do a combination of both, like we would do in mechanical ventilation. So either we increase the tidal volume by non-invasive ventilation like CPAP or BiPAP, or we increase the respiratory rate again through positive pressure ventilation or through mechanical ventilation, and that way we treat type 2 respiratory failure. So this was how we treat type 1 and type 2 respiratory failure in clinical practice. But again, as I said earlier, type 1 respiratory failure is more common as compared to type 2 respiratory failure, and in your usual clinical practice in an emergency settings, you will see type 1 more sort of common as compared to type 2, while type 2 is usually seen in very severe what you call like forms of the respiratory pathologies, and usually these children, they end up in an intensive care. So if you're working in intensive care, you might see type 2 respiratory failure more commonly as compared to type 1 respiratory failure. So I hope this has clarified the concepts of how we treat type 1 and type 2 respiratory failure. I've tried it to simplify it in the easiest language possible, and I hope that clarifies the concept. If you still got any questions, I am always open to questions. Please feel free to drop me a question. I'll be more than happy to answer them. Have a very good day. Take care, and bye bye. I'm signing off.